is a keynote session in the theme of Resilience in Healthcare Research by Dr. William Davis from Center of Disease Control and Infection.
Sure. Is it okay? Working. Good morning. So my name is Bill Davis, and I'm an epidemiologist with the U.S. Centers for Disease Control, based at TUC, the Thailand Ministry of Public Health, U.S. CDC collaboration in Nonthaburi. So just a brief bit of background. The CDC, as I mentioned, is part of TUC. The Flu Division has projects in Thailand, Bangladesh, Myanmar, Laos, and Indonesia. And our work includes human and avian influenza surveillance, influenza research on burden and cost, vaccination programs, and pandemic preparedness. And our main goals are to reduce burden of influenza, to be prepared for a pandemic, and to help determine what viruses go into seasonal influenza vaccines. So that's a lot of work in influenza. So why do we have so much work in flu and also maybe so much funding for this? So first, there's a high burden of influenza disease, and we want to work to reduce burden of disease. But second, all of these programs, so whether it's surveillance, or burden estimates, or cohort studies, or vaccine programs, they're designed to help us be better positioned to respond to an influenza pandemic. So that's why influenza has so much funding, and why the US government and also the Thai government are concerned about influenza. So with flu viruses, we know there's always risk of a pandemic because of high rates of mutation in the viruses. So I think you know where we have a pandemic on right now. It's not influenza, but because we had research platforms and partnerships in place already, partly to get ready for a pandemic, we were able to adapt our research quickly and respond to data needs for understanding SARS-CoV-2 to direct policy to slow the outbreak. And so my talk today, we'll talk about resilience in healthcare research, and I want to specifically focus on influenza research that we did during the COVID-19 pandemic and how we adapted that to learn more about SARS-CoV-2 and COVID-19. So I'll give you several examples of platforms we had in place for flu and show you how we adapted them. And there's a list here, but I'm not going to go through it to keep the talk kind of short. So when the pandemic hit, there's several research questions that came up. More than just these questions, but general, we want to know who's getting sick and who's the vulnerable population. What are the risks for infection? What are risks for severe disease and risks for death? What's the current rate of transmission? What's the natural progression of disease? What treatments work? How well do vaccines work? Are other interventions working, like masks or social distancing? And so we wanted to quickly leverage our research programs to answer some of these research questions. So for my first example, let me talk about sentinel surveillance for influenza. So the goals of flu surveillance are to understand circulation. And we want to know, when is the seasonal epidemic occurring? We want to identify abnormal circulation. So do we see a lot of flu cases when we're not expecting it? Because that might tell us a pandemic is happening. And we want to collect viruses to inform flu vaccine strain selection. So to do this for influenza, we collect data from people with respiratory illness. So we take a nasopharyngeal swab and we do a RT-PCR test. And we can test these respiratory cases for influenza, determine the percent positivity among all respiratory cases, how many have flu. So this is the data that we're using to track circulation. And then we can also test which flu viruses are circulating. So we work with the governments in Bangladesh, in Laos, and Indonesia, and Thailand to run these sentinel surveillance systems for flu using SARI and ILI. So I think you may know SARI is severe acute respiratory illness and ILI influenza-like illness. So these are WHO definitions. So we can do the same thing for COVID-19. And during the acute phase of the pandemic, all these countries had separate surveillance for COVID because you had so many cases. But hopefully if COVID is decreasing and moving forward, we need to maintain surveillance for COVID-19 so we can start to understand more about how the virus is being transmitted. So of course there's similar presentation, there's respiratory illness, sampling and testing are the same, nasopharyngeal swab, RT-PCR tests, same viral transport medium. So we can use the flu surveillance system to collect data about SARS-CoV-2 transmission. It's a little bit hard to see that map, but here's an example of our surveillance in Bangladesh. We have 9 surveillance sites in the country, and if they're positioned well around the country, that's enough surveillance sites to help us understand what is transmission like in Bangladesh. So they collect information on hospitalized respiratory cases. They test for flu or SARS-CoV-2, and we have % positivity then of test results. And we can monitor trends over time, triangulate data with outbreak response data. And moving forward, we can start to monitor to see if SARS-CoV-2 has seasonal transmission or not, like influenza. So here's some data from that since January of last year. So you can see on the x-axis is month and year. On the y-axis on one side, we have % positivity for influenza, which is a blue, and for SARS-CoV-2, which is orange. And then this line you see here is the total number of respiratory samples collected. And so what we saw in January 2019, we have a seasonal flu epidemic in Bangladesh, which is what we would expect. And then by April 2020, they started detecting a lot of SARS-CoV-2 cases. So this is not national surveillance for SARS-CoV-2. This is the flu surveillance that's identifying SARS-CoV-2. So they had cases before April, I think. As you can see, we have one peak of SARS-CoV-2, small flu peak, and then a big peak of SARS-CoV-2. And so it shows flu seasonality, then low flu transmission, then SARS-CoV-2 transmission. And so we have success in our influenza surveillance being able to detect SARS-CoV-2 cases. And so when we have SARS-CoV-2 surveillance, we're asking demographic questions, asking about age and sex and maybe risk factors, but we can also ask about vaccine status. And so of the surveillance cases that test positive for flu or COVID, we can ask about if they were vaccinated. And from that data, we can calculate vaccine effectiveness, or VE. So we call this a test negative design. And we've done it for influenza, and now we're starting to do it for COVID-19. So we're doing that in Thailand with influenza and SARS-CoV-2 sentinel surveillance. So we work with the Ministry of Health to run influenza surveillance sites where you see all of these stars. So the blue stars are sites that are now collecting data for vaccine effectiveness calculations. Purple stars are just doing influenza surveillance. And in Bangkok, we have a surveillance system in private hospitals. Because a lot of people use private hospitals, and we do not want to miss that population. We only started this project in September of this year, so we do not have enough data to calculate VE yet. But you can see we have our 6 hospitals listed along the top here. So far, we have about 1,000 respiratory specimens for inpatients and outpatients. If you look here, we've had 6 influenza cases since September, so not very many, and 82 SARS-CoV-2 cases, so a few more of that. And we asked if they were vaccinated or not, and we see numbers. The % of people receiving flu vaccine is around 2 to 4%, 20% at the Queen Sirikit site, but that makes sense because that's a pediatric hospital. More children receive flu vaccine. And then we see how many have received COVID-19 vaccine, 5% up to 30%. And so that's a lot lower than the national vaccination rate, but these are people who are testing positive for SARS-CoV-2. So of course, you'll have a lower vaccination rate among cases than non-cases. So we still have not analyzed data yet, but the data will be very useful for understanding how well vaccines are working in the Thai population. So we have VE data globally, but it's important. There's a lot of factors that are different in each country. So we need to understand, how does this work in Thailand? And so this can inform vaccine policy. So another example I want to talk about is a healthcare worker cohort that we have in Thailand. So in 2017, the Ministry of Public Health talked to us and said they wanted to start a cohort of health workers to learn about influenza, but also to be ready to collect data in case there is a pandemic. So it was very good thinking because 2 years later we had a pandemic. So we had this cohort already in place in 4 hospitals, and the main purpose was to study burden of influenza disease among health workers, absenteeism due to illness, and exposures to flu. So the hospitals are in the provinces highlighted. They're all kind of close to Bangkok because we had to do sample transport to Bangkok and we wanted it to be easy to transport samples. So not scattered around the country like our flu surveillance. Anyway, in 2019, we launched a study on encounter patterns among 240 health workers in inpatient wards. So that's how many contacts do they have with patients. In 2020 and 21, we studied 2,200 healthcare providers and followed them for influenza incidents. And we did weekly surveillance for respiratory symptoms. Symptomatic cases were tested by PCR. And we also estimated the cost of illness and how often they missed work because they were sick. To save time, I don't want to go into too many details of these, but we found that, oh yeah, great, thanks. Yeah. Oh yeah. So we found a lot of encounters, obviously, between healthcare workers and patients, implications for infectious disease transmission prevention, and policies around sick leave. So we had some policy recommendations for that. For incidence and cost, we had 244 symptoms among healthcare providers, 2,200 healthcare providers, detected no influenza, but the median duration of absenteeism was 8 days for sickness, and the costs associated with that were about 210 baht per illness. And so this is also informing sick leave policy and infection control in hospitals. So then the COVID-19 pandemic hit, and we got funding to do some COVID-19 studies with the same group of healthcare providers who are already enrolled in our study. And so this gets back to some of the research questions. Who has been infected? What is the immune response to vaccines? And especially the immune response to mix and match vaccines, and also getting a booster dose. So Thailand was one of the first countries to start mixing and matching vaccines, and nobody in the world knew if it would work or not, including WHO. And so Thailand Ministry of Health and our partnership was one of the first studies to actually generate data on this, which is very useful for Thai vaccine policy and also global policy. And so we needed data to understand infections, inform policy, and global policy. So we started the COVID-19 study. So in April and June of last year, we had protocol developments, talked with all our collaborating hospitals on what we were going to do, IRB approval. 6 different IRBs had to approve the new protocol. So I know if you've done that, that's not an easy task. And in January of this year, we enrolled 600 healthcare providers in 4 hospitals. And so what we've found so far, just to briefly summarize, is a very high acceptance of vaccine, no vaccine resistance. We better understand immune responses to vaccine and the mix and match combinations. We understand moving forward, we need to think about what are the risks for lower immunity to vaccines, and we're going to follow some breakthrough cases, people who've been vaccinated and then later got sick. And so again, this is informing vaccine policy. And so a few more examples, some new research that we have going on, but with old partners from Thailand. So we have long-term collaborations with Ministry of Public Health partners in Chiang Mai and Bangkok, with IUDC, in Nakhon Phanom and other sites. And the relationships are already established, our working relationships and our trust between partners. And so because of these ongoing and strong partnerships, this made it easy for us to quickly start up new projects on COVID-19. So we started a general population serosurvey for SARS-CoV-2 virus in 4 cities, and also we supported IUDC with emergency response work in Bangkok. So the serosurvey, we recruited 1,200 people in 4 cities in Thailand, in Chiang Mai, Nakhon Phanom, Bangkok, and Phuket. We took baseline serum, and then we take 1 serum every year to test for SARS-CoV-2 virus. We also call each participant each week and ask if they've had COVID-like illness symptoms. And if they have, we invite them in for a swab and a test. We then added an additional protocol, and we would take serial serum collections after infection or after vaccination, so we can understand waning immunity. So this is also, we're just finishing up the first year after starting it. So here we have each week, so week 1 is about January of last year and to present, the number of participants on the y-axis. And the lines show people who reported COVID-like illness. And the green bars were negative for COVID and the red were positive. So you can see how this trend, it kind of follows what the Thai national surveillance data was reporting for the entire country for COVID. And so this is our data following COVID symptoms and testing. Yeah. So through the first year, about 1% of participants had COVID. This is consistent with national surveillance data. More evidence to indicate that the first year of outbreak response in Thailand was highly successful in controlling the outbreak. So after the pandemic is over and we talk about lessons learned, we have evidence to support the interventions that were in place were successful. For the waning immunity study, data analysis is underway, but I have nothing to tell you today. And for impacts, this will also inform vaccine policy in Thailand, and it will help to identify populations more vulnerable to SARS-CoV-2 infection. So a few more short examples. Influenza vaccine networks that we have in Laos. So we knew from the 2009 pandemic that countries that had a strong seasonal influenza vaccine program were better at implementing vaccine for pandemic influenza. And there's a reference there for that. And so our priority is then to strengthen seasonal influenza vaccine programs in all countries, because this not only reduces burden, but it's also a pandemic preparedness activity. So in Laos, we're supporting ongoing work that's supporting a knowledge, attitude, and practices survey, so we can understand COVID vaccine hesitancy, support for modeling work, looking at burden of the disease and which populations to vaccinate. Laos has vaccines, but they're not as far along as Thailand is, so they need to think about prioritizing populations a bit more. And supporting COVID-19 vaccine rollout support. So from partners we had in Laos with seasonal influenza vaccine, we're easily able to work on these programs. And then finally, post-immunization evaluations. So we did an influenza post-immunization evaluation in Thailand a few years ago, and later this summer we're going to do a COVID-19 post-immunization evaluation here in Thailand. So the data collected there can help identify problems in vaccine rollout. So you can shift your implementation and help it to be more efficient. So it looks at vaccine coverage, which populations are being missed, timing of vaccines, and logistics. And the goal here is to improve coverage and improve efficiency of vaccination. So I gave a lot of examples of research projects we had that we had to modify or start new when the COVID-19 pandemic hit. And we had a lot of challenges doing this. It's easier said than done. So for launching new projects, some challenges were developing and writing and implementing new protocols with multiple partners, getting ethical research approvals from partners' institutes and our own institute, linking epi data and lab data for new projects, smoothing data flows. IT work is always a bit challenging. And then challenges with the ongoing surveillance and projects we had were with sample transport, with lockdowns and limits on transportation, lab testing capacity, because they had so many COVID tests, they didn't have much staff to do, or reagents to do other tests, PPE shortages, staff shortages. Care-seeking behavior of patients changed, because people were afraid to go into the hospital, so they're afraid to get COVID. So that was a challenge with interpreting data. We had to change our interpretations a bit from before. And also maintaining work on projects when they were not a priority because most of the focus was on COVID. So we had a lot of lessons learned, and we were able to identify some keys to success for resilience in this research. So with influenza, we're always thinking about a pandemic. So we were maybe well prepared for this, or maybe better prepared than other fields of research. So we do have examples of successful resilience in healthcare research. And so some keys that I had already discussed are that first, we had research platforms in place that we were able to adapt to collect data on COVID-19. And I showed some examples of data that we have collected in the last year. This is probably the most important key, and I put it second, but the strong partnerships and close working relationships with Ministry of Health, with partner hospitals, and with some universities we work with. And so this made it easy to problem solve together because we were already friends and we were already used to working together. So we could problem solve to adapt protocols and launch new protocols easily. And we understood each other's IRBs and we knew what they would want and not want, so that made that easier too. And then lastly, we were collecting data to inform outbreak response and to inform public health policy. And this was seen as very valuable data by our partners and by our partner governments and by my own government. And so that was motivating for everyone to get the research through and to start collecting data. So a lot of people to thank, and thank you for inviting me to give the talk. I guess I can take questions.